I am going to be talking about some work my team and I have been doing around implementing food insecurity screening and response in a healthcare system in Portland. Funding for my team, much of it came from a quality improvement grant from Pfizer, so disclose that. The health system I work for is called Legacy Health. We're based in Portland, Oregon. We have 6 hospitals, including a children's hospital. We have 40 specialty clinics and 28 primary care clinics. And I'm going to start off presenting some key results and then dig into how we got to those. So just over 5 years ago, back in 2019, we started on our SDOH screening journey. And since we began, we went from having 1 clinic that screened for food insecurity to all 28 of our primary care clinics screening. We have expanded from having no hospital screen for any health-related social need to now, as of a couple of months ago, implementing in all 6 of our hospitals. We've also expanded to include not just food insecurity, but we're screening for a total of 5 HRSN domains. At the same time, we have distributed about 4,000 bags of food to patients who have identified as food insecure annually. And we are consistently screening about 80% of our patients for food insecurity. That's the question I get asked, though, is how on earth are you screening 80% of your patients for food insecurity? And so that's what I'm going to present on today. We'll start off with the fact that we used a lot of available tools that are available to all of us. Really relied on the National Academies of Science, Engineering, and Medicine's 5 A's to develop a framework for how to approach this in our health system. I'm really going to focus on that awareness piece, or our screening, and then a little bit on our assistance piece. But just know that we are doing work in all of these different spaces. And then our other large toolkit has been, my team was selected in 2021 to participate in an Institute for Healthcare Improvement Learning and Action Network around integrating screening and response for social needs into healthcare. And so they were really supportive of our work and helpful in teaching me, a health services researcher who didn't get any QI training in her doctoral or master's program, what the heck a PDSA cycle was and how to use it, and some other quality improvement tools. So QI people love their run charts. We'll start off with one of those. In 2019, we started working with the Accountable Health Community Study, and we had 3 clinics who agreed to sign on for this work. I serve in our internal medicine residency faculty and was able to convince our leadership that our internal medicine residency clinic should participate in this study, so that was 2 of our clinics. And the 3rd clinic was another clinic that I regularly partner with for work around maternal health, and most of their patients are pregnant women with Medicaid coverage. So those were our early adopters, and they saw the value of this work. You can see that this has taken time, right? So we started out real small, we've iterated, we've grown, we've iterated and grown. So I really want to call out that this is, over 5 years of work to get to where we are. Our 4th clinic that we added later in the project, that was late 2020. So we're talking November, December 2020, and I'll think back to what that time in life looked like. This came about because our community health needs assessment was done for one of our regions, and food security was identified as a major need in that region. And certain individuals who maybe got to sit on the community health improvement plan process said, hey, why don't we add food security screening to one of our goals? And lo and behold, that got added, and then we needed to actually implement that in the health system. So in 2020, we added a new site. We engaged with our clinical vice president of population health, pulled in the manager of care management for the whole system, and then the clinic manager, and then the social worker in that clinic. And we started meeting with them regularly to talk about how might we implement the screening so that it wasn't going to be an extra burden for the staff, that it was going to be respectful for our patients, and it was actually going to get documented in a medical chart. and they were really open to it. One of the things that we had learned from our time with the Accountable Health Community Project was that if we limited our screening to Medicaid and Medicare members, that actually added quite a bit of work burden to our front office staff who had to scrub patient charts ahead of time to determine who would be included in the screening. And so instead of doing that, we just screen everybody, which based on what was said earlier today, I feel really justified on just asking everyone about their needs. So we worked with them to develop a workflow, and then we continued to meet with them for about 6 months after that initial implementation to kind of work through the kinks, figure out what was going well. And one of the things that I would really say is one of our early meetings, our clinic manager's like, hey, it's going great. People are screening, feeling really good, yeah. And then I shared with her the screening data that I was able to pull out of the back end of Epic, and she goes, oh, that's not what I expected. I said, oh, okay, well, let's talk about that. So she was able to go back to her staff and kind of identify some of the areas, that were kind of the holdup, and we could see the improvement happen after that. So this is, well, that's actually not as bad as I thought. Here's our workflow. Critical to this work, and I think critical to why we see 80% of our patients being screened, is that our screening is baked into an existing workflow, right? We have what's called a pre-visit summary. It asks all sorts of questions when a patient comes in, and the screening questions for food are at the end of that intake form. And so it's not an extra piece of paper somebody has to grab. It's not an extra data entry element that they have to go find. It's already baked in, and I think that that's been really critical to this work. So in 2021, after we got that kind of laid out, we added the remaining 4 primary care clinics in that region to the screening and did very similar processes with those folks, in addition to having another champion for the work. Early 2020 was our big push. So we here went from expanding from those small set of clinics to all 28 primary care clinics. But before we dove into providing, to doing that work, we did 2 really important pieces of work ahead of that. One was a 3-part data review process, which is something that IHI provided training in and support for, and then expanding our food bag program, which I'm happy to talk about during discussion, but is a critical element of this work. So the 3-part data review really here looking at both needs and assets. We looked at our medical record data. We were able to stratify our food insecurity screening by patient demographics, look at clinic locations, really understand who is screening positive. And then we did in-depth interviews with our care providers and also with patients who had been identified as food insecure. And from that, we were able to better understand what was working well and what wasn't in our efforts. So one of the things that was really important that we learned that helped propel this work forward was that a lot of our patients and staff didn't feel comfortable engaging in these conversations, and having the screening as part of the workflow made it so it was normal. And so our patients felt more comfortable talking about it, and it really helped to gain that, yeah, we should have this as part of our typical work. We also identified that many of our patients were reluctant to use existing social services. So one of the reasons our health system was okay with going down this food security path was like, oh, lots of resources in the community for food. We can do this. What we heard from patients and staff was folks had had their benefits turned on and off so many times they didn't know whether they could get benefits, and so they just stopped trying. They'd gone and been treated really poorly. Or the other one, which I always find fascinating, is somebody else needs that food more than I do. I don't want to take it away from them. And so we saw, okay, actually we do need to be doing some of this food support in our system. And then last, I'm not a social worker. My naive belief was that our social workers were spending time with folks and had time to walk them through the processes of signing up for WIC and SNAP and all of this. And they quickly said, no, Megan, we don't have that time. We get enough time that we can give them a resource list. The one exception to this being our patient navigators, community health workers, who are able to really spend time with folks. And so that has led us to really recognize the power and the need for those individuals in our workforce. One really important learning from the food bag portion of this that our staff shared is that having the food bags really made the food insecurity screening, like tiptoeing into that space, a lot easier for them because it allowed them to provide some sort of immediate relief to patients instead of just documenting in the chart. And then they also noted that the food bag really helped them build rapport between the patients and the staff that allowed them to have a deeper conversation. All right, so 2022, we hit 28 primary care clinics, got all of this implemented. We're now in a space of really being able to look to see how are we doing? Are we hitting the screening rates that we were hitting with those early clinics? Are we struggling? So we were able to look at our clinics and then did this lovely little QI project. So this is month-over-month data, and this is 2021 through 2023. That blue line are clinics that started our work early, and so you can kind of see their growth over time and the percent they were screening. That orange line is our later adopters, so these are the clinics who started in February of 2022. And so we were tracking to see, are they kind of like growing at that same pace, or where are things going? You can see here, we saw that there was kind of this lag happening. Like, all right, what's going on there? And then we were able to dig into clinic level data to see how the different clinics were performing on screening. And we were able to identify a couple of clinics who were screening fewer than 70% of their patients, and a couple of clinics who were screening more than 90% of their patients. And so went out on Teams, did in-depth interviews with these clinics to really understand what was going well and what wasn't. And so we learned from them that communication, not just with those managers, but your frontline staff is really key. So we had our frontline folks, our social workers, involved in that initial work. And then they were not really involved in the later work. And the later rollout came through an email that went to clinic managers that had about 20 other things in it. And the MAs who were really in charge of the screening didn't know anything about it until it showed up on their pre-visit summary. And they're like, excuse me, why am I asking about food? I work in healthcare. So those clinics weren't doing so great. From that information, we were able to meet. We have this lovely group of folks who work in quality improvement in our system who work with the medical assistants. We met with them, kind of brainstormed how we might improve screening. They put together some educational materials, including this lovely FAQ sheet to share with MAs. And it had a bunch of when a patient asks me, why on earth are you asking me about food? What do I say to them? Is this going to be kept private? And then also at the bottom, some information about why is this work generally important so that they could understand. And this has really been helpful. I'll just go back to my lovely run chart. We had a really big improvement after that educational intervention, so that felt really good. So we've continued some of that work. So I'm going to wrap up with kind of where we're at. As of this last year, we've added an additional 4 domains to our health-related social needs screenings. We started piloting screenings for all of those 5 domains in one inpatient setting, and we've just recently rolled that out to all 6 settings. And we're developing a really groovy dashboard that I'm so excited about. You can see blue lines here are representative of food screening, and this is in our outpatient settings. And you can see in June, when we added our other domains, boop, the percentage of screenings that happened. And then we have some nice summary data down here that's talking about percentage of patients screened as well as the percent positive. We can dig in by payer, we can dig in by clinic, and do some really nice QI work. Got something similar for our inpatient clinic. You can see we've got some work, or inpatient settings, we've got some work to do here that I'm looking forward to. And then I'll leave you all with some take-home messages. Really start small, one clinic, figure out what might work, and then expand. For us, having that food bag program was really critical for getting buy-in from our staff and having them feel good about it. This is a space we're really curious about with adding all of these other domains that we don't have. I don't have a housing bag I can hand out or a utilities bag. So curious how this is going to kind of play out as we move forward. Making sure you're building your screenings into an existing workflow. If it's out of the workflow, it's going to get lost. Finding the right clinic partners, right? As I was saying, it's not just your managers, it's not just the high-level leaders, it's also your frontline staff. Investing in our community health workforce so that we can find that support. And it's not one and done, right? Constant, continuous quality improvement, and keep monitoring the data. Thank you. This is our big team, a lot of folks working on this. That's my contact information.